but whatever. Uh-oh. Does that look different? It does, doesn't it? Well, it doesn't really matter, does it?
No.
All right. You can still see it. So let's talk about disaster nursing. So this here is simply definition. So emergency versus disaster. The basis of this is that an emergency can be handled by the local community. So if something happens within Memphis, a few cars pile up on the expressway, our fire department and police department can handle that. That's an emergency. But we define a disaster as something that is much larger scale. This might be a review to you, but a review never hurts. But the key with a disaster is that backup assistance is needed, and emergency response people from other communities come in to help in that situation. We think a lot about natural disasters here, but the resources within that community can't handle a disaster. Emergencies, they can't. All right? There are basically two types of disaster, natural and man-made. So natural disasters, we think about storms and earthquakes and things like that, diseases. And man-made disasters can be intentional or non-intentional. So an example of an intentional man-made disaster would be an act of terrorism. That would be intentional. Remember that the word terrorism, it means to inflict fear upon someone for political or religious beliefs. That might be in a slide later. But things that may be not intentional is maybe a building collapse or an oil spill or something like that. All right? This is another definition: multiple casualty incident, 2 to 20 to 99 people. So if 100 people are injured, that's a mass casualty. If 99 people are injured, it's multiple. Right? So that's just a definition that you need to remember. And one is not included because that would be a what? Single incident, right? Again, terrorism is man-made and intentional. And this is the definition of terrorism, but I just think about it as an act that is meant to inflict fear in another community or group of people by another group of people for religious, political, or ideological reasons. And they obtain, power by doing this. There's lots of weapons. We'll focus mostly on bioterrorism in this lecture, but lots of different weapons that can be used during terroristic threats. And bioterrorism is just disease with terrorism. So one of the things that we worry a lot about is anthrax. Anthrax is a bacteria that is gram-positive. 95% of cases of anthrax are generally cutaneous. And this is what a lesion would look like if it were cutaneous. You see that it's got this necrotic center with a raised erythematous border. So be able to identify that lesion. But the type of anthrax infection that is most worrisome is inhalation anthrax. When a person is exposed to anthrax, inhalation is 5% of that, but that percent, the people that have inhalation anthrax have a very high mortality rate. So if inhalation anthrax is not treated, it has a 95% mortality rate. That's why it is a good choice for bioterrorism. If you get it, you're probably going to die if you don't get antibiotics, right? But the early signs are flu-like, so there's early flu-like symptoms. But it causes pulmonary edema, not necessarily pneumonia. All right? It can lead to sepsis. If a person has been exposed or suspected to have been exposed to inhalation anthrax, they will get doxycycline unless they are allergic or too young to receive it. Because remember that a person that is less than 8 cannot receive cyclines. Penicillin, Cipro are also good choices, but the penicillin, that's usually used for non-bioterrorism, which means probably cutaneous infection of anthrax. So if a person happens to get a cutaneous infection of anthrax, which is possible just in the community, the people that are at highest risk of getting this infection are people that work around a lot of soil, so farmers and things like that, because anthrax generally lives in the soil. So that person would get something like a penicillin in that family. We don't think about this a lot, but penicillins are good to treat the skin, especially augmentin. We usually, we use bigger antibiotics than we need a lot of times. But so these are some examples of antibiotics, but just realize that doxycycline is first line, but also if it is known inhalation anthrax, they will get a combination of doxy and another type of antibiotic like a macrolide, vancomycin, clindamycin, and maybe rifampin. All right, so know this right here, this little side note. They'll probably get a combination, but doxycycline most likely. We know that the corticosteroids would help reduce inflammation in the lungs, hopefully reduce the risk of pulmonary edema. Respiratory care is priority. And there is a vaccination for anthrax, but it's only for people who are at high risk of being exposed to this, and usually that's people in the military who are overseas.
What about farmers?
No. So these are some priority nursing diagnoses: impaired skin integrity because of the cutaneous lesions, risk for infection because of that impaired primary defense, and of course impaired gas exchange related to that ventilation-perfusion mismatch with the pulmonary edema. All right, which you are very good at understanding. The vaccine takes 18 months, right? So it takes a long time to get a person immunized to anthrax. So they would have to do lots of planning before this person would go into a situation in which they would be possibly exposed to it. Right? 18 months to get the 5-shot series of anthrax. So, in our situation, if you're working in a setting like an emergency room or something like that, and someone has been possibly exposed to anthrax, this person must be decontaminated. Anything that they have on should be put in a plastic bag and sealed and eventually destroyed. The person must be bathed from head to toe with soap and water, and this is to wash away the spores. Okay? Remember that anthrax travels by spores. So this person must be washed with soap and water during the decontamination process. And anything that person has come in contact, any surfaces, any materials, just a 1 to 10% solution, or a 10% solution of bleach in water will take care of it. We don't want to pour bleach on the person, because the person gets in water, right? Before the person is decontaminated and during the decontamination process, any person that is in contact with them must have full body protection and also a HEPA filter respirator. This is not an N95 mask. This is a HEPA filter mask. All right?
What does the PPE stand for?
Personal protective equipment. After the person has been decontaminated, they require no special precautions. Even if they do have an infection of anthrax, as long as they are on antibiotics, they are not considered contagious. And of course, it would be part of our responsibility to make sure that this is reported to local authorities and the CDC, right? There's a suspicion of anthrax exposure. Did Mr. Napier tell y'all his story? It's really funny. Okay. So it was probably, years ago, around 2001, with all the, with 9/11 and all of that. He said that his father was glued to CNN for days straight and couldn't stop watching it. And they were talking about, how things had been received in mail and powdered substances in the envelopes. And he was just obsessed with it. And he thought that his dad was, hilarious for being so obsessed with it. So he played a joke on his dad. He came into the house or the room that he was in, and he said, "Dad, something's in this envelope. It's like a white powder. I just opened it." And his dad started freaking out. And so you see, the first thing that his dad did was smell it. Which is the absolute last thing that you want to do, right? So,
Smells just like anthrax.
yes. Now you got it. So, he said that his dad was not happy, and
It was his dad or father-in-law?
no, his dad. I want to
Okay.
say father, but it was his
Okay.
dad. Yeah. So yeah.
That's okay.
He has a fix. So the father-in-law.
So if you know of, if you suspect anthrax, don't sniff it to see if it smells like because you will then have inhalation anthrax. So he thought it was hilarious. All right.
That's funny.
Another good choice for bioterrorism would be smallpox. Smallpox is similar to the varicella virus. It is the variola virus, and it only infects humans. So a lot of times, and I'll think about it with varicella as well, because it spread the same way. Many people believe that chickenpox, varicella, is spread by contact. It is not. It's spread by inhalation. So smallpox is the same way. It can be spread by contact, but most likely it is spread by inhalation. They're very similar viruses. So there is a patho to this, but generally, the person is coughing, sneezing, and droplets would be inhaled, and the variola virus is in those droplets that would be inhaled. So it infects the respiratory tract, and the immune system kicks in, and the virus multiplies in the lymph nodes. And then from that, and also in the bone marrow, but from that, the virus enters the body, the bloodstream, and then goes to the skin and causes eruption of the vesicles. But until the person has the rash, the smallpox vesicles are not contagious. All right, so realize that they're contagious at the point that lesions develop. Remember, the prodromal period is the period at which the virus is replicating rapidly in the body, and the patient can have signs and symptoms during that period. And during the prodromal period of smallpox infection are these flu-like symptoms. ST is sore throat, not sinus tachycardia. So, but once the person's infection is active, they are then contagious because at that point they have lesions. So you notice that the person with smallpox, this is a good picture, but the smallpox lesions generally begin on the face. So the highest concentration of lesions that you're probably going to see is on the face with smallpox, because what we would say part of the differential diagnosis, things that we're trying to rule in or out during diagnosing something, would be chickenpox. But remember the differences in chickenpox lesions versus smallpox lesions, in that chickenpox varicella is concentrated on the trunk. So the person with chickenpox will have more lesions in the trunk, and then it spreads outward. But smallpox, highest concentration in the face, it spreads out. All right, that's the difference. Because they're just large vesicles. Smallpox is highly contagious, and it has a high mortality rate, just like anthrax. Anthrax has a higher mortality rate, but smallpox is more contagious, right? Because anthrax isn't contagious. It's only the person would only get anthrax if they were exposed to spores, right? But smallpox would spread within a community. 30% mortality rate if not treated. Let's see. And another reason why it's a good choice for bioterrorism is that no one is really immune to smallpox anymore. There are persons, I think, what is it, 1972, around that time, they stopped giving smallpox vaccinations. And they did this because it was considered to be eliminated. It is still around, and it is stored in 2 labs in the world that we know of. One is right down the road in Atlanta. But the thing is, there are some people who are considered immune to smallpox, but also realize that those people who did receive the vaccination probably have not very good immunity anymore. That immunity has faded over time. And we don't do titers to smallpox or anything. but also realize that the nurses that have been immunized, those are the nurses that would be chosen to take care of patients if we had a smallpox outbreak. But it's still likely that that person is not immune anymore, because that immunity, because it's not natural immunity, it fades after a while. So just realize that. What else? All right. Complications of smallpox, this conjunctivitis, corneal abrasion or ulcer here. All right. Infection especially is a big deal, because you have lots of impaired all over the body, especially the face, all these lesions with impaired skin integrity. So this person is at increased risk of skin infections, cellulitis, abscesses, which could lead to sepsis. Remember, it does cause an infection of the respiratory tract as well, so they are at risk for infection in the lungs, and which could lead to pulmonary edema. It is a virus, right? So we don't have a treatment for it, really. There are antivirals, but antivirals in general are crappy medications. Our HIV medications, our antiretrovirals are very good, but that's about it. Antivirals, don't work so well, especially Tamiflu. It's crap. What else? So, and then of course, you have these secondary infections, respiratory infections, skin infections, penicillins, cephalosporins could be used for that. Persons that do have immunity, they do have antibodies to smallpox. We can pull their blood, their plasma, and pull those antibodies out and develop an immunoglobulin to administer to people who have smallpox. But, this is a very lengthy process. And again, the vaccination is still around, but only people who are that would be at risk for being exposed to it are vaccinated. So there are still some military people that are vaccinated for smallpox. I forget exactly what this link is, but I think it has to do with the isolation procedures with smallpox, and I'll talk about it. And just like anthrax, same nursing priority diagnoses. The person with smallpox infection should be on high precautions, contact and respiratory isolation. All right? So the person with anthrax needs no isolation, right? Standard precautions, after decontamination. The person with smallpox, all isolation, right? Respiratory and contact. And by putting the person on respiratory isolation, you also take care of droplet isolation, right? What else? The person is at risk for hypovolemia due to sepsis and things, fever, skin pain. So skin care, nutrition has to do with healing, right? It is possible to give a person, if it's available, the vaccination for smallpox after exposure, because there is that prodromal period in which the virus is replicating. If the person receives the vaccination before the active phase of smallpox, it can reduce the severity of that infection. So that is also an option that could be considered. If this person doesn't have a lot of complications, doesn't need to be in the hospital, we don't want them in the hospital because they are highly contagious. We want them to go home. All right? So get them out of the hospital as soon as possible. But if the person hasn't shown any active infection, no lesions, but we know that they've been exposed or possibly exposed, we put them on a fever surveillance. So for 18 days after exposure or possible exposure, if they have a fever, I think this says 100.4 under that, right? 0.5, they should be suspected in quarantine. All right? If a person has had an infection of smallpox, it is best to cremate them if they die. All right? If they have the active infection. If you got the vaccine, you don't have to be cremated. But anyhow, and I think that cremation doesn't have a lot of religious barriers anymore. I think at some points in history it did, but most socio or groups and religious affiliations accept cremation now. Most.
So, if you get smallpox, you just pretty much either get better or you die.
That's with most diseases, isn't it?
Well, there's nothing really to give. I mean, there's nothing
Right, yeah, there's
nothing
supportive
really-
care.
Yeah.
There's supportive care, skin care. 30% mortality rate, yep. That's not what most disaster preparedness. So this is it's a very important to us nurses, and we have to be leaders in the situation of disaster preparedness. So this just means having a plan in case a disaster does happen. Nurses are involved in all parts of this, especially surrounding healthcare and bioterrorism, educating the community, and also, of course, we should educate ourselves about this. And I've probably said this many times, but nurses are the largest healthcare group in the country. So there are more nurses than anything else. There's more nurses than respiratory therapists, there's more nurses than doctors, there's more nurses than anything. So we have a lot of power. We don't use it. But we are charged with this. So realize that as the largest healthcare group, we play a big role in planning, delivery, and response to disasters. Education, already said, and we're involved. All right. So this is topics for training nurses in disaster preparedness. BLS, I think, well, every nurse should have BLS. Different settings would require different training and specifications. Communication during a disaster is different than not during a disaster. Some things would not be communicated during a disaster that would be communicated in a regular emergency or general hospital setting. Certainly you wouldn't need to know those things, but just realize that these are topics that are important for training nurses in disaster preparedness. In the general setting, if you're working and something goes out, it doesn't work, what do? You take it out of operation, right? But in a disaster, that might not be feasible. We might have to work with things that don't work well, or half of it's broken. What else? Team infection control is a big issue. Nurses are very good at this. Right? Psychosocial support, we are too. All right. So disaster preparedness is a cycle. So during the non-disaster stage, this is when planning and prevention should occur. Right now, right? There's no pending disaster that we know of. Pre-disaster means that we know something's coming. A hurricane is out in the middle of the Caribbean, and it's coming. This is pre-disaster. This is where there's some planning maybe happening, but this is where evacuation is starting to be planned and mobilization of things to get people out of harm's way. The impact is when a disaster would occur. The immediate time after is the emergency period, and this is when we are responding to the disaster, the after effects, treating patients, and mobilizing. Lots of triage will be happening with nurses at this point. And reconstruction would be the last phase of disaster preparedness, and this is when we get the community back to normal and begin, again, planning and preventing future things from happening. All right? I think in your book there's a picture, and it's like a circle. You know, the key is to know that non-disaster stage is when we should be planning to prevent and respond to disasters. And in our situations, probably we are most focused on our hospital's disaster preparedness plan. Southwest also has a disaster preparedness plan, which you probably have no idea about. But we have one. It's posted in the nursing offices. So all facilities should have a disaster plan. So let's see, what else?
So they'll be coming to the nursing annex, I'm assuming? If the disaster hits up,
There's a basement over there. Yeah. I don't know the exact plan either. But if we had to evacuate somewhere, I think that it would be in the basement. Annex, that's a good idea. Yeah. Community or agencies or even families should have a plan. So the ages of members should be taken into account. Children and older people have very different needs in certain situations than middle-aged or young adults. Let's see. Contact person and meeting place. A good thing about this is that a good thing, or a good plan for this is to have a person outside of your area that you would contact. So if you have a family of a bunch of kids and you get displaced and you can't find them, we want to text Meemaw who lives in Chicago. So we're on the coast. So everybody's so we need to contact the person out of that area. That's our go-to person, our contact person. So they can say, your mother's here, so and so is here. Get to them because maybe you can't communicate within that area. Even in the best mode of communication during a disaster or something, storms or whatever, is text messages. Because a call might not go through. A text message might take time to get through, but a text message goes up and it's in the cloud and it just circles around until it can get down to where it goes. So that's how text messaging works. So don't try to call, so it'll just hang around, say cloud, but storage place somewhere. It circles until it gets down to where it needs to go. It might take 25 minutes, but it's going to get there. Text messaging is the best way. Different dietary needs of people. So realize that very young people, babies, have different dietary needs than older people. People that have certain diseases or whatnot, diabetics, have different dietary needs. Medications, medical needs is a big deal. I'll talk a little bit more about that with different populations. But so medications is important here. Whatever. Disabilities, functional needs. A person that is in a wheelchair is going to have very different needs during a disaster, and that should be planned. All right. And also, don't forget your pets. Let's see. In general, here's a nice little list here for a kit, for a disaster preparedness kit. Individuals should really have these, especially in high-risk areas. One thing that I forgot to add to this was what as soon as it goes to last time, an axe should also be part of the disaster kit. A small hatchet.
And a gun.
I was just thinking that.
For the zombies.
The zombie
What you'll notice here is that nothing on this list requires electricity necessarily. A cell phone with charger, but there are hand chargers for cell phones. Right? So that could be part of a disaster kit. It's kind of funny to talk about this, and I'll tell you a funny story again. I think it was, when was it? 2000. When did Memphis flood? Half the city was flooded. I think it was 2009 or 10. Well, I was convinced that my neighborhood was going to flood. Because I live when you're driving down Peabody near Cooper, you go down a hill.
Yeah.
And then you kind of go back up a hill. It's like my area is going to flood. There's drainage ditches all around there because this is at the bottom of the hill. It's like the water's going to come up out of these drainage ditches, and I'm going to be flooded. So I had a kit, and my friends all made fun of me. And I have a nurse's bag, and I took all my stuff out of that bag and put all the stuff in there. And had jugs of water from the fridge. And I said, y'all are going to be laughing and begging to come drink my water. You're not coming over here. But there was, I think there was a lot of rain and stuff around that time too. And my pool flooded. It was mud all out. I was like, I'm going to be underwater. I wasn't, thank God. I've since had disassembled mine because that's what but I probably should keep it.
Keep it every spring in Memphis.
A lot of people know that we lost our home in a tornado in 2008.
Oh, wow.
And we didn't know it was coming. We had just moved in 5 days before. We live out in the country, so we didn't have Dave Brown telling us to go get in the bathtub or whatever.
So we got a phone call, and it looked like the sky was turning. It looked like two clouds were falling out of the sky, and those were tornadoes coming straight for us. You don't have time to put on shoes in a situation like that. And when 29 windows in your house shatter, and the insulation, the roof is gone, but the insulation falls down in the house. And that was, knee high on me. So you want real shoes. put your damn shoes on. When you really think the tornado's coming, put some real shoes on,
That's
not
true.
flip-flops.
I was in that same one at Union, and I didn't have shoes on, and my feet were all bloody, and
We didn't, and I mean, I made sure to go out and find shoes for my kids. I wasn't concerned about my dog that I loved or the cat. I was concerned about there was glass and nails everywhere. I need real shoes.
So there's a tornado warning. Put shoes on.
Put shoes on. And don't, and I still
Tennis
tell my
shoes.
kids when the tornado warnings come, don't take your shoes off until I tell you to.
Yeah.
You put your shoes on and leave your shoes on because they were little at the time. They were 3 and 4, and I screamed for them, and they actually came to me. And I picked them up, one under each arm, and booked it, and we made it. But you know, it was terrifying.
Where'd you go?
We went to a closet in my master bedroom, but so.
in that house. February 5th.
Oh, that was Hickory Ridge Mall and Union took a big step back out of it, but, you know, we had massive damage. We weren't back in our house for a year.
Wow.
Well, when I moved here and I put my kids in daycare, they made us do a disaster plan and have a plan,
Mm-hmm.
which really frightened me because there's no earthquakes where I come from. So,
Who required you guys to do that?
the daycare where I
Okay.
took my son when he was a little guy, the Jewish Community Center, they made us put together a disaster bag for in the event that there is a earthquake, and that we would also we had to have a big plan in place, like who is going to come and get them, how are we going to walk to where we got to be,
Wow.
and all that stuff.
I've never heard of a lot of facilities doing that, but you know, we are waiting for the big one here.
We're all in fall.
They just had
It was the daycare.
Worked with us last night or something.
Really?
I think it was, I heard it on the news this morning.
I don't know how that works. Does it mean that a big one's coming, or I would rather a whole lot of small ones happen and release the pressure gradually? But
I like that.
there's been earthquakes in California recently too, in Chile. There was a large one in Chile, so California's probably on that same tectonic plate as California. I should put it back together. Like somebody mentioned, I think we're just all going to follow the Mississippi River.
Yeah, that's what
Yeah, I'll throw it out there.
I did this list for this Mactoda for my honors project.
Okay.
So I have a list for every age group from infant on up to adults if anybody wants it.
Yeah, good.
And what you're supposed to
What am I missing?
have. A lot of stuff.
These are some basic things.
Yeah, because I put like water, you're supposed to have water. You put, for a kid, like little kids, you have to have formula,
Right.
the dry formula. You put toys, something for them to have from home. I had the radio, but I have the kind of cheap plug your cell phone charger into, and it charges your phone to keep it up. I did have a hatchet on there, and then I had rope. Because
Rope.
at times you're gonna have to you might have to clear stuff away from your house in order to be able to get out. So if there are trees or anything, you have to use a hatchet and clear them away. Yeah, and that was the other thing is that you need to have that for everybody, and you need to know what it is.
Chris said your roadside assistance card. I don't think that they're gonna. I don't think Allstate's gonna come get you.
T-Dot not gonna lose
All right. So to follow up with what I was talking about, we also need to keep focus again on populations that have special needs. Children have very special needs. Children often have disorders and diseases that aren't common in adults. So asthma is a very common childhood disorder. And if a child ends up in an asthma exacerbation, doesn't have their medications, they could die. So make sure within your kit you have available asthma medications if the child has asthma. And also realize that during something, maybe there was a tornado and the house basically exploded, and there's going to be debris and dust and insulation flying everywhere. What's that going to cause? An asthma exacerbation, right? Because they're inhaling all these irritants. I mentioned ADD and ADHD. You might think, well, who cares if they have their Vyvanse? But also realize that a child that has attention deficit disorder, that is true ADD, they would be distracted very easily and could become, displaced from their family or someone that can take care of them. So this child is very distractible. Diabetes, type 1 especially, you would think about in children. So their insulin should be packed in a kit or available and be able to go. So a child ends up in DKA. That's not good. They can't get emergency care immediately. Kids are at increased risk of respiratory infections. I mentioned that with everything flying around or whatnot. And wounds, kids get hurt easier. They fall down. And so medications that might be a part of a kit would be antibiotics and histamines, pain medication. Unique nutritional needs. So children, become very easily dehydrated, and older people also become easily dehydrated. Keep in mind that any child that is less than 12 months old needs some form of formula or breast milk for nutrition. The older they are, maybe they're 11 months, they probably could get by without having formula. You could feed them. They're usually eating table food at that time. But they still need some form of formula or breast milk until the age of 12 months. Breastfeeding, of course, is a disaster plan within itself. The mother has nutrition, she carries it with her. So, as nurses, in general, every day, we should encourage all mothers to breastfeed. Psychosocial implications with children, they're easily overwhelmed, they're not cognitively mature, and they may not understand directions or know when to seek help if they're hurt. Increased risk for post-traumatic stress syndrome and stress disorders related to disaster. So they can have effects from this disaster for many years afterwards because they weren't able to properly comprehend what happened. So it can cause a lot of stress later, and acutely, of course. All right. I mentioned this inability to follow directions. They can't escape danger. They don't move around as well, especially if they're very young. What else? And we think about kids, and just realize that, especially smaller kids, they have what? Big heads compared to their body size. So if your head is larger, you have an increased risk of hitting you on something, right? Kids have weak neck muscles. They fall. A kid is at an increased risk of having a head injury than an adult. Also, their skulls are thinner, especially if very young. The vessels are more fragile, so they have an increased risk of a traumatic brain injury if you have a head injury. All right? So this is one reason why a child is more easily dehydrated, because the increased permeability of the skin and the larger body surface area. So they have an increased risk with burns and cuts and things like that, from bleeding out more easily, and with burns. So a small flame would maybe only burn an adult's arm, may only get 9% burn, but it might burn half of a child's body, which would be probably fatal. Right? What else? You remember the unique respiratory tract of children? The airways are smaller, and they have a faster respiratory rate. They have a faster respiratory rate so they can get more oxygen in. They just have to be faster to keep up with the demands of the body. Adults, our airways are larger. We breathe slower because we have larger lungs. So if a child is exposed to something like anthrax, they're going to breathe in more of it than we would because we breathe slowly. So realize that too. If a child gets into a situation where they have inflammation in the airways, especially an asthma exacerbation, compared to an adult, that child is going to go out much faster because airways are simply smaller and they'll close off sooner. Right? It's important to know. Another population that is, or a population that is forgotten, is the mentally ill. So these people have unique needs as well. Medications, especially, would be a big thing here that these people would need to have available in an emergency or disaster situation. One plan that we could do in that area that is an increased risk of, we have 3 hurricanes a year. We would encourage that person to get a depot injection. So they don't only get their antipsychotic medication, they get their schizophrenic every 3 months, right? So that would be a good choice for a plan for them. So cognitive alterations obviously is an issue with persons who are mentally ill. coping mechanisms, disorientation, and disturbances of reality. So if they already have a mental illness, they're at increased risk for further mental illness related to this disaster. All right. Is that the last slide? It's a quick lecture. There's a chapter in your book. I don't know what the chapter is. Maybe it's around chapter 10. I don't know. Is it 10? 7. And so I usually don't just say read the chapter, but that's a good chapter to read for this concept. All right. I'll post information on triage sometime tonight, or sometime tonight probably, and just ready to go over that on Thursday. And it won't be a lengthy lecture. I probably could combine these two lectures, but I'd get in trouble if I did that. So, any questions? So hang around if you want to take this quiz, these practice quizzes.
Mr. Sales?
Yes.
I've been having some confusion it's not about this, it's about the last one, about what they're able to do. I'm confused. They can put an IV in, but they can't put the medicine. But then,
in general, we think about LPNs not being able to be involved with IVs. But they often have further training to do so. So you just think about the basic level of an entry level.
But they can dress the wound.
We can do wound care, yeah. But if you had to choose, there's 4 patients and they all need wound care, you would have to choose which one maybe the RN would attend to and which one maybe the LPN would attend to. And obviously the RN would take care of the more complicated dressing change. Right, that would just be a good choice overall.
Right. I was just looking for like a general view with LPNs. I don't know if I'm
Yeah, can you LPNs help her out? A general rule of thumb? I don't think there is one.
as to what they can do. I mean, not what they actually do, but what the book would, the test would ask us they would do.
When you go to one of the facilities you're working in, they will give you a job description, so you don't have to be super concerned about it.
Yeah, the facilities have their own policies based on that, and often it is, a policy that's they restrict people with more than what their training will allow them to do. Sometimes you have special privileges like IV situations and whatnot, but in general, what you need to know is with the delegation of assignments, that's a big situation or a big responsibility of clients. So you'll have 4 choices, and you'll have to basically decide which ones are appropriate for LPNs and which ones are appropriate for RNs. And there will be keywords on the difference.
What is that? Right. For now, right?
What LPNs assess?
Whoever is initial.
The most complex patients will be assigned to RNs. The less the unstable patients. And stable patients are assigned to LPNs.
Just focus on initial.
Right. Initial assessments are I'm not exactly clear on that. Can you LPNs help us with this question? It's my understanding to just think about LPNs not being involved with IVs. But with your basic LPN license, can you insert an IV?
No, we can't.
But you can use it.
Yes. It depends on your facility where you work at.
It depends on where you work. So
At the med, my nurse was the LPN, and she was the best IV inserter on the floor. So.
All LPN programs have initiated IV curriculum in their
They have,
schools
okay.
as of like 2009.
Push meds. You can't.
You can't push IV medication.
Right.
Well,
Or pain
well, we
blood.
can give laces, and we can give Benadryl and stuff like that, but you can't push like IV narcotics and pressors and stuff like that. Right.
That depends on
cardiac,
the state.
cardiac.
Right.
Yeah. Depends on the state. Yeah.
So how about for the exam? Like what? Like I know that reality is a little different than the test. I was doing some practice questions and I'm starting to get confused.
If you want to say the class, you will test on.
But nursing school, it's supposed to just remember the RNs and everybody else.
I think about LPNs being not involved. Whether that's after practice.
I mean, we have nursing students.
Well, they work under the delegation of one's license. Your instructor is responsible.
Sometimes they just go, you okay, Jimmy?
Any more questions?
Are nurse extern considered UAP?
A nurse extern will be a UAP. They do not have a license. And then you might even get into a situation if maybe an LPN has decided to go work in a hospital as a nurse extern. In that role, they do not have a license. So I'm not going to try to trick you on the test, but realize if that happens, so I think in some facilities, externs make more than entry-level LPNs. So that LPN might choose to work as an extern while in nursing school, but has an LPN license. They are not working under that LPN license. They're working under that extern position license. But an extern is a UAP. Nursing students are you can do things because you have an instructor there who's an RN supervising you. Whether they directly supervise or not, they're still there and are supervising. Any more questions? All right. What commission?